Yes, okay, so I'm back. So we have two topics, maternal pelvis, fetal skull, and hyperemesis gravidarum. So hyperemesis gravidarum, if it comes with 5 marks also, bro, you don't have a lot of time, just write what you fucking know. Okay, first we write definition. Definition, it is a excessive vomiting such that it cause deleterious effect on the mother, fetus, or it incapacitates mother from day-to-day life. And we have three definitions to write about this one. One is electrolyte imbalance greater than 5% body weight loss and electrolyte and ketoacidosis. Okay, that is dehydration. There's three definitions over. Then what we write is predisposing factors and pathology. Predisposing factors is if she's a primary psychological age, a young age, primary psychological age. Psychological important is like she's having disturbance at home, if she's unwanted pregnancy, she's having any previous son. Past history is important. And low BMI is important. Other than this, based on the pregnancy risk factors important, molar pregnancy, twin pregnancy, previous history of this one, then ectopic pregnancy, any of this can cause. Okay, pathology wise, up we have most important vitamin B1 deficiency, thiamine deficiency, which cause Wernicke's encephalopathy, can cause spontaneous myelolysis. Lysis. It also can cause Korsakoff psychosis. Then in the blood, it can have metabolic acidosis, hypoglycemia, hypoproteinemia. It can have acute renal failure. It can cause cirrhosis, stomatitis, all that stuff. It can cause in the this one severely. It can cause jaundice. It can cause acute renal failure. It can cause Mallory-Weiss syndrome, that is tear in the esophagus due to retching, that is forceful vomiting. Okay, this is the pathology. So what are predisposing factors? We finished. Pathology we finished. Okay, then very important clinical features. In clinical features, we have vomiting, dehydration, hypoglycemia, tachycardia, and hypotension important. Oliguria important. See from top to bottom. Up, few convulsions, memory loss, confabulations, dehydration, vomiting, tachycardia, hypotension, renal oliguria, anuria, and jaundice. Then detailed history is important. Why do we confirm pregnancy? We can see pregnancy-related causes of hyperemesis and assess the severity. Okay, investigations, hemoglobin, urine for ketone bodies, urea for serum for electrolyte, LFT, RFT. In LFT we have to in RFT we have to do for the fuck man, urea, creatinine, pH. Then in three cases we have to admit. This is important. Three cases where we have to admit where antiemetics are not effective, antiemetics are not tolerated, and medication for other conditions are not tolerated. Okay. Then what is the protocol management? Complications you have to prevent. You have to treat the condition and hospitalize in case of emergencies. Okay, in these three indications. Prevent complications. How do you maintain that? Renal hydration. We give antiemetics for the vomiting. Supplementation of vitamin B1. We remove risk factors first thing. Okay, psychological, and we maintain nutrition. Okay, bro, this you have to kind of by heart. So let's just remember. We give antiemetics. In antiemetics, what do we give? First, we give antihistamine. Second, we give ondansetron and metoclopramide. And then third, we give is corticosteroids. So first one is in antihistaminics. We give promethazine, doxylamine, prochlorperazine. Okay. Then metoclopramide and ondansetron. Then corticosteroids, hydrocortisone, 100 milligram BD. In hyperemesis gravidarum, we have electrolyte abnormality, dehydration, vitamin B1 supplementation, dehydration, nutrition via NG tube, electrolyte monitoring. Then we have B1, this one we supply. Antiemetics we give for retching. Then we give psychological care for risk factors. See, if you go heading wise, no management, you can see. Management, first definition. Weight loss we manage via nutrition. Then risk factors, psychological we manage that. In pathology, CNS, we give B1 supplementation. Then we give metabolic acidosis, that is electrolyte profiling. Then uh, then we give antiemetics. See, like this, you'll not forget. In nutrition, what do you give? Dextrose with vitamin B1 together. Oral antiemetics. Antiemetics, three tests: H1 blocker, then ondansetron, and then hydrocortisone, 100 milligram BD. Antiemetics over prevent complications. What are the complications we can look for? Renal failure, acute renal failure. So we urea creatinine and ketone bodies. LFT, retching, malarial vitamin B1 supplementation, and electrolyte. Okay. What is very important is this uh, management is written, clinical features, pathology. This is the most preventing complications. All of this is there. And then one very, very important thing is uh, nutrition. How do you give? We start with dry carb, then we go to semi-solid, then we go to liquid. It is opposite of surgery. This is in hyperemesis gravidarum. I hope this is good enough. So we have definition, investigation. Investigation we did know hemoglobin, hematocrit, hemoglobin, hematocrit, urea, LFT, RFT, uh, vitamin B1 levels I get, mallory USG for severity, USG, then treatment protocol from beginning, from definition, weight loss we give nutrition. Nutrition, what is important? Gradual discern is important. What nutrition we give is important. After that, we go for the pathology. We give vitamin B1 supplementation, risk factors, psychotherapy. We give metabolic acidosis, electrolyte discern, and antiemetic therapy. Or the complications again, Wernicke's encephalopathy. Metabolic acidosis, ketosis, hypochloremia, renal failure, jaundice, that is fatty liver disease. Then we can have weight loss. We can have weight loss. We can have Wernicke's encephalopathy, pontine myelinolysis. And I think I can write a little bit more about this. We'll see once this video is over. Okay, and then we go to next question. Next question is about